Dr. Johnson, you're muted at the moment.
Sorry about that. Thank you, Thomas. I appreciate being able to participate in the conference. I have to ask the audience's indulgence, and I apologize for my bronchitis that I will snivel and cough through this presentation. We have a toddler living with us who goes to daycare, and consequently, I'm in the recovery phase of a non-COVID infection. Anyways, I'm a neonatologist at the University of Minnesota. I've been there for 42 years, and up until 1985, I knew nothing about international adoption or adoption in general. And then my son, Gabriel James Sunil Sai Johnson, joined the family, and I realized that not only I didn't know anything about medical issues in adopted children, but the rest of the profession didn't either. There was nothing in any medical textbooks about adopted children, and there were only a handful of articles, most of which dealt with hepatitis B and Korean adoptees. So shortly after Gabriel was adopted, we and my colleagues and I started the Adoption Medicine Clinic, and our goal was to, one, increase the amount of information that there was about medical conditions in adoptees. The second was to provide post-adoption screening for children who arrived with their families to make sure they didn't have any acute or chronic illnesses. And the third, which I'm going to talk about today, is to provide information to families and help them interpret the medical information that they had received on their adopted children in order that they can make a well-reasoned decision about whether they could fulfill the needs of that child if they brought that child into their family. Next slide, please. So we're going to talk about assessing a child's needs from afar, how we do it, what are the problems involved, and what's the role of genetic testing. I'm going to talk about why a pre-adoption medical review is so important, and talk about the 3 waves of adoption in the United States, the goals of a medical review, gathering and interpreting medical information from other countries, the role of genetic testing, and finally a summary. Next slide. So the first wave of adoption in this country began shortly after the first White House conference on dependent children that Theodore Roosevelt sponsored in 1909. As a consequence of that conference, we moved from institutional care for dependent children to more family-based care of dependent children. And Americans, as Ryan has pointed out, were very anxious to adopt. However, it was adoption very different than it is right now. First of all, in terms of priorities, it was finding children for families rather than families for children. So the needs of the family outweighed the needs of the child. There was adherence to rigid racial boundaries. This was primarily white children going to white families. And as Ryan pointed out, employing secrecy to avoid stigma and social sanctions for both the birth and adoptive parents. Of course, it was not appropriate to be a single parent at that time. There was no way most single women could support a child. And certainly there were tremendous social sanctions against becoming pregnant and bearing a child if you were a single parent. And also adoptive parents faced sanctions and stigma if they were unable to conceive. So it was a secretive process. It involved normal white infants only, and children defined as having special needs were considered unadoptable. And these included children of color, older children, sibling groups, children with handicaps, and also children who would experience abuse or neglect because it was felt that the traits of the parents were going to be passed on to the child and that the environment did not make a difference in which that child was raised. These children were irretrievably affected by their parents' genes. Next slide. We began to see a change in adoption in the end of the 1960s, early 1970s, when the pipeline of white infants from white single parents started decreasing. In 1969, there were 60,500 placements through private agencies and independent adoptions. And by 1975, that had dropped to less than half of that. Two things happened during that period of time. There was more liberalization of support for single parents. So single parents actually could afford to have children at home. And there was also Roe v. Wade, which allowed abortion on demand, which severely cut into the number of children that were available for adoption. During this time, we saw an increase in the number of at-risk international and special needs adoptions. This was certainly not enough to make up the difference for the number of white children that were not available for adoption any longer. But we can see that international adoption really took off after that period of time. Next slide. In addition to the changes in the children, we also saw changes in the practice of social work. We began to get more into what was best for the child rather than what was best for the family. So the child's needs came first and the parents' needs came second. US intercountry adoption always spiked after either warfare or natural disasters. The first big wave came after World War II when the military personnel stationed in these countries started adopting war orphans. This continued after the Greek Civil War, after Korea, Vietnam, El Salvador, and then when the USSR deteriorated and opened up the orphanages of Eastern Europe, Central Asia, and China, and finally the Haitian earthquake in 1910. A couple of families to look back on in terms of poster families for intercountry adoption and special needs adoption. One was Harry and Bertha Holt. Harry went to church one Sunday night and heard a speaker talking about all the children left after the Korean War that were mixed race, that were offspring of the children and Korean women, and came home and said to Bertha, I think we should adopt some of these kids. And indeed they did. They already had 6 birth children, and Harry took off, went to Korea and brought home 8 children from Korea. They founded the Holt Adoption Agency, which was a pioneer in placing international adoptees, and most intercountry adoptions can, or the popularity can certainly be seen emanating from the Holt family. A family that specialized in special needs adoption were the Carl and Helen Doss. Carl was a Methodist minister. He and Helen were unable to conceive and adopted a white child. But then when they tried to increase their family, they were frowned upon by most adoption agencies because of their income. So they went for special needs kids, and most of these were mixed race children of a number of different ethnicities. They eventually adopted 12 children. All of these children were adopted from the United States. These were not international adoptees, but they certainly adopted kids that were categorized as special needs and became known as the One Family United Nations. Both of these families shared a characteristic which is still quite pervasive within the community of individuals who adopt internationally, and that is a deep religious belief or deep altruism that they should go out of the box and help kids find families who may not be acceptable to many children, many families in the United States. Next slide. Special needs adoption also increased after the number of white infants decreased, the availability of white infants decreased. They increased also because of medical outcomes and support services, the establishment of agencies who specialized in special needs adoptions and positive outcome studies. Next slide. So we enter the early 90s knowing that many of the children being adopted had medical issues, whether they were acute or chronic. Some of them had special needs. And then we started seeing kids coming from Romania, followed up by children from Russia and other Eastern European countries, as well as China. And we began to see the developmental effects of adversity. These children grew up in very neglectful circumstances and started showing the effects of early adversity in their adoptive families. Next slide. This is also the time we saw a vast increase or doubling in the number of children coming from abroad, placed in American families. And we began to see the effects of early adversity and the outcome of these kids. Also, during this period of time, we recognized that most of the kids in foster care had also experienced adversity in early life and were at risk of a number of medical, developmental, and emotional problems that their adoptive families had to deal with. So it was during this period of time that agencies began to realize that virtually all children were at risk, all children were special needs, and began to tell their families that all families should have a medical evaluation of their child's records prior to adoption to make sure. And now remember, this is the time when families needed to know that they were able to meet the needs of their child before they made the decision to adopt the child. Next slide. So what are the goals of a pre-adoption medical review? Well, adoptive families must be able to meet the needs of the child. We do not want to place a child in a family who is unable to meet those needs because that does not serve the best interest of the child. So first of all, we have to decide what are the needs of the child, take that medical information and see what's going on, permit the family to determine whether they possess or have access to the needed resources. How will meeting those needs affect all members of the family? Many of these families also have biologic children or other adopted children in the family. And they have to be encouraged to look beyond the child's photo to establish appropriate expectations. Next slide. So one of the things I like to talk about with families is the distance between expectations and reality, because expectations minus reality equals disappointment. And if you have a lot of disappointment, you run the risk of adoption dissolution. And that's not what we want to have. We want to have that child placed in a family that's going to be able to meet their needs for the rest of their life. So we want to make sure that we provide information necessary to permit the full spectrum of decision-making options for the parents. Now, a successful adoption does not mean the absence of challenges. Certainly we know that as a parent, there are always challenges involved with having a child, but optimally these challenges should be expected and surmountable, which is why we feel so strongly about making sure that families know what the diagnosis might be with their child and what issues might be present, what treatment might be needed, and what might be the outcome. Next slide, please. So I thought it might be helpful to talk about who adopts internationally. There are single and two-parent adoptions that are possible. They're generally very well educated. They're financially sound because they have to qualify. The US government requires a certain level of financial stability to bring a child into the country. They also have a stable interpersonal relationship. They've gone through a home study and been approved by an agency. Almost everyone has access to good health insurance. They're willing to step out of the box and adopt a child who may not look like them or may have a medical problem. As I mentioned, they're often motivated by religious beliefs or altruism, and they're confident in their ability to overcome adversity, which generally works in their favor. However, some families may be overconfident in their ability to deal with specific issues. Next slide. So to give you an idea, virtually all children now being referred for intercountry adoption have special needs. I went through 104 referrals, sequential referrals in the 6 months or so before COVID shut down adoptions in many countries, and looked at the number of children and whether or not they appeared to be normal children. And over 95% of the kids that we reviewed in our clinic were children who had special needs. Next slide. And looking at the special needs, and this is a busy slide, but just look at the bolded text. These are problems that may lend themselves to genetic testing in order to make more definitive diagnoses. And these include a lot of developmental problems, some specific medical issues, clefts, congenital heart disease, disorders of sexual differentiation, hearing loss, etc. So, the number of children coming with problems where genetic testing could be helpful is pretty significant. Next slide. So we are, our abilities to help families is determined by the information that we are given, which ranges from very little to very extensive. And the quality ranges from dismal to exceptional. I put the picture of the child up there because often we get information that's just totally uninterpretable, as the facial features on this one child. The quality is often determined by the quality of the medical care in the country of origin. And for instance, we get very good information from Korea, not bad information from China, information from Haiti, some of the African countries, et cetera, where the healthcare system is not particularly good, is very suspect. We also have to deal with the quality of the translation. Some information is translated by individuals with very good medical background, and others not. And then we also have to look at the comparability of medical terminology, and also just the way diagnoses are used. When we started seeing kids from Russia, we would see terminology that included things like hydrocephalic syndrome, spastic quadriparesis, encephalopathy, myotonic syndrome, all of these things that look like terrible neurologic diagnoses. Yet the kids were, in terms of their motor development, completely normal. And we learned that the terminology was an artifact of medicine under the, communism, where diagnoses were often applied to children just because they might be suspect, and then eventually removed as the kids proved to be normal. So we have to take that into consideration as well. Next slide. So helpful information includes everything that we would normally use to evaluate a child in the United States: history, measurements, laboratory tests, developmental information. The more detail we can get, the better off. The more points in terms of growth we can get, the better. The more laboratory tests, the more standardized developmental information, and the more detailed information about the child's disability, including on what they base the diagnosis. Photographs and video are very helpful, but countries have become more reluctant to provide information when it might wind up being shared with other individuals other than the biologic parents, or than the adoptive parents. Next slide. Then we have to interpret the information. In terms of growth, we have to look at, we use the World Health Organization growth curves. We know that most children in foster care, which really is exclusively Korea, have normal growth, but most institutional care causes significant growth impairment, where the 50th percentile in institutional care is about 1 standard deviation below the 50th percentile on the World Health Organization curves. Development, foster care, except for some gross motor delay, up to 8 to 10 months, because they carry the kids all the time and don't provide any tummy time, is pretty normal. Institutional care, gross and motor delays up to 8 or 9 months, and then these kids start catching up. Language delays that become more significant with time. Social behavior, there's indiscriminate friendliness. There's also, in very, very bad orphanages, institutional quasi-autistic behavior that's been described by a number of investigators, that is different than true autism, but it's very, very difficult to tell the difference from afar. Interpretation of laboratory tests is often challenging when we don't know when the test was done. And also the interpretation of age is difficult when age is assigned. In China, children are abandoned. We don't know what their ages are unless a note is left. In Ethiopia, for instance, we often have children who are underestimated in terms of their age, because they know that people want to adopt younger children. So it can be very, very difficult to ascertain age in these kids, even with things like bone age, which also lags behind in malnutrition and chronic stress. Next slide. So what about genetic testing for children in pre-adoption review? We have to ask a number of questions when we're asking for any additional information than what might be included in the original referral information. First of all, is the desired information obtainable? And on the right, I've got the top 10 placing countries in the last fiscal year that we have information from, which is 2020. 67 countries, 1,622 children, and you can see that these countries range from very high socioeconomic countries with good medical care and the capability of doing genetic testing, like Korea, to countries with that are essentially unable to do any kind of sophisticated medical care, like Haiti. So you have to ask what the system in that country is capable of doing. And part of that issue of whether that information is obtainable is who's responsible for getting the information. Sometimes I have to ask physicians in countries for their approval to get information, and if they don't think it's warranted, they will not give approval. Who pays for these tests? For instance, in China, it's the orphanage that has to pay for the test, and they have a limited budget and they may not want to do it. And third, can I trust the results? Most of the time you can, but there are situations that we've encountered where the results are patently false, and you have to ask whether or not those tests are worthwhile doing. Another issue is, does waiting for the results put the child well-being at risk? Remember, most of these kids are living in institutions and they are suffering adversity during that period of time. And if it's a long time waiting for that test, you're putting the child at further risk simply during that delay. And then finally, is it necessary? I always have to ask myself who actually wants the information. I have lots of family as a neonatologist, excuse me, where I think that genetic testing is warranted because I want to know the diagnosis. We're physicians, we want to know what the problem is. And it's not that big a deal to the family. They don't particularly want the information. So I have to ask myself, is this something that's going to help the family, or is this something that I just want because I want to know the answer? Another question is there other way we can get the information that might be sufficient? For instance, we see kids with potential neurofibromatosis. These are young infants. They have a number of cafe au lait spots, maybe not enough to make the diagnosis, but we would like to have genetic testing so we can tell the family. But in some situations, we don't really need the genetic testing because we have more than sufficient number of large cafe au lait spots, and we have a father who is known to have neurofibromatosis type 1. And in that situation, you really don't need the genetic testing to inform the family that this is a likelihood. And finally, will it influence the family's decision? Again, some families really don't want to know and will accept the child without the testing, and they're already bonded to that child, and whatever the testing is, it's not going to make a difference. So let's go through a few situations that we've encountered over the last few years. Next slide. So this is a child from Russia who came with a diagnosis of tetralogy of Fallot and cleft palate. We look at her facial features. Her nose is a little bulbous, a little columnar, somewhat small jaw. This is a child who I felt very strongly would need genetic testing to make the diagnosis of velocardiofacial syndrome, or 22q minus, short deletion in chromosome number 22. Now, these are conditions that are treated surgically and can be very successfully treated. And the family knew that, that's fine. We can deal with the tetralogy of Fallot, and we can deal with the cleft palate. But what a diagnosis would tell us in this child is that this is a child who's also at risk for attention deficit problems, and also may be at higher risk for schizophrenia later on in life, because we know that those go along with 22q minus. So it would be helpful for this family to know that information, if that information was available and could be done. Next slide. So this is a 2-year-old boy in China who's got known developmental delays with hypotonia. The child is microcephalic and has a clinical diagnosis of Mongolism, but no chromosomal testing. So is this a situation where we should pursue, asking the orphanage to send out and get a karyotype of this child to make a definitive diagnosis? Well, if a family had come to me and just had fallen in love with this child, but didn't have the faintest idea what Mongolism meant, or didn't understand what it would be like to parent a child with Down syndrome, yes, I would want to confirm that with the family. But there are many families who come to us wanting specifically to adopt a child with Down syndrome, and there are other ways of confirming the diagnosis. We can get more pictures. We can get more developmental information. We can ask them to provide pictures of the sides of the head, better pictures of the face, pictures of the hands and feet. And we also know that Down syndrome is a very common diagnosis in Chinese orphanages these days, and we can be pretty confident that the orphanage directors are good about picking up a diagnosis of Down syndrome. So it we may not necessarily need to get a karyotype on this child in order to inform the parents any further. Next slide. So this is a child, an 18-month-old from China who had an incidental clubfoot deformity. But you can also see that this child has a disorder of sexual development. Superficially, this child has the genitalia of a young female. However, if you look at it more carefully, you can see that the labia are rugated, which indicates some probable testosterone secretion, but the child has no phallus, and really also no obvious clitoris either. The vagina appears closed, maybe a closed hymen. But we also knew that this child had palpable testes in an XY karyotype. So we did have some genetic information. Now, pursuing a definitive diagnosis on this child from afar would be very difficult. This is a complex workup best done by a pediatric endocrinologist with broad experience in diagnosing disorders of sexual differentiation. There is no single genetic test that will tell us the answer as to what this child has. But really, the genetic testing doesn't get to the major issues that this family will face. And the major issues are the long-term issues of, yes, we know what the sex of this child is, but we do not know what the gender identification of this child will be later on. Will this child identify as a male or as a female, or may have no sexual identification? Families need to know and be aware that they are choosing to parent a child who may not fit into society. If this family has a binary view of gender, this may not be the child for those parents. If this child is going to grow up in an environment or a state which has laws legislating against individuals like this, it's going to be very, very difficult for that family to deal with it. So parents need to think very, very seriously about what it might mean to parent this child over the long term. And looking at the chromosomes, even though they're part of the diagnostic workup, is not going to answer that question for them. Next slide. This is another child, a 40-month-old girl who was a product of father and daughter incest in the Philippines. This child at 40 months was the size of a 10 to 11-month-old, the developmental age of 11-month-old, also had a patent ductus arteriosus, microcephaly, and strabismus. This is a geneticist's worst nightmare. Have every recessive gene possible that might be a problem. Again, it would be a very extensive workup in a country where that kind of workup is not going to be easy to do. But in essence, we really do not need that genetic workup to inform the parents that the likelihood that this child will have lifelong problems in terms of development and growth, and that it will be and to inform them that it's going to be a challenge to parent this child, and that they will have to consider what it's going to be like to being a custodial parent for the entire lifespan, for their entire lifespan, as well as to plan for the likelihood that this child will need custodial care after they're gone. Next slide. And finally, this is a 19-month-old male who was hypotonic. He had developmental delays with regression. He did have a genetic consultation in Korea, a rather extensive one. They did identify some areas of concern in his genome, but wanted the biologic parent's DNA, which of course was impossible. Also did Fragile X and myotonic dystrophy due to the facial features of this child. Those were both negative. And so the question was whether to pursue further genetic testing. Next slide. But the parents, when I posed this, said, at this point in our adoption process, we are not going to change our minds. We just want to have as much information as possible to give him the best care when he gets home. So really, further diagnostic testing was not done, and the family had already made a decision. They had fallen in love with him. This was their child, and they were going to bring him home and try and do the best they could for them. And in this situation, further testing really wasn't going to help them anymore make that decision. Next slide. So in summary, right now, we are finding a family for a child and not a child for a family. Virtually all children now available for adoption have special needs of one sort or another. Many have very very significant long-term medical and or behavioral issues. And what we want to do in a pre-adoption review is set appropriate expectations. The family needs to answer the question, can we or I meet this child's needs? And genetic testing can be helpful, but must be thoughtfully employed, considering everything else that goes into making that decision. Thank you very much.